Quick, what do you think would go up on the board if Family Feud asked what the causes of anemia are? I'll tell you this much. Sickle cell disease would probably be high up there. It's been a public health focus for African Americans for decades. Approximately 1 in 600 Black Americans have sickle cell disease, and roughly 10% are silent carriers. Clearly, sickle cell disease is a big deal, and that's why we're devoting this whole sketch to it. We'll start off with a discussion of the sickle cell hemoglobin polymer, and follow it as it does its characteristic damage to red blood cells and end organs. A little background before we dive right in. Behold the river Styx, mythical barrier between the land of the living and the afterlife. This is the story of Orpheus, son of the Greek god Apollo, and the backdrop of our treatise on sickle cell anemia. Orpheus, undisputed master of the four-string lyre and the original rock god, many millennia before Van Halen, was a legendary poet and musician. Myth states that his riffs were so rad that even the birds, rocks, and trees could not resist the urge to dance when he played. This Lothario married young to a nymph named Eurydice, but tragedy separated the two when Eurydice was struck dead by a viper bite. Orpheus, stricken by grief, played the saddest jams known to music. Seriously, way heavier than anything by Cobain or Staley. This compelled the gods of Olympus to send Orpheus to the underworld to seek out his wife. There, the unorthodox hero used his charm to swoon the guardians of the underworld. Like Charon, the ferryman charged with carrying the souls of the dead, and even Cerberus, the three-headed hound of Hades, whom we'll meet a little later. In this sketch, the sickle-shaped ferry boats represent those classic sickle-shaped red blood cells. The actual sickle in this scene, held by Charon in the front there, symbolizes the abnormal hemoglobin molecule inside the cell, which is called hemoglobin S or HbS. This sickle hemoglobin is produced by a missense mutation in the beta-globin gene on chromosome 11. See the chariot bearing Eurydice into the underworld? Incorporated into the wheel is our recurring symbol for hemoglobin. And to remind you of a beta-globin subunit specifically, we've designed the chariot to resemble a beta symbol on each side. This mutation, GAG to GTG, substitutes a glutamic acid for a valine in the 6th amino acid position of the beta-globin subunit. Hence the valine death veil worn by Eurydice as she reaches out to Orpheus. The replacement of negatively charged glutamic acid with a nonpolar valine increases the hydrophobic interactions between hemoglobin molecules. I mean, this is the river Styx we're talking about here. Not surprised by the water phobia. Hydrophobic interactions facilitate close overlap and polymerization of hemoglobin S, which we tried to depict with the sickles overlapping and clumping together. Can't have too many spare sickles when you're the ferryman of the underworld, you know? Reaping souls and such. The polymerization of deoxyhemoglobin S is the primary and indispensable event in the molecular pathogenesis of sickle cell disease. The polymer has the form of an elongated rope-like fiber, which aligns with other fibers, forming a fascicle and distorting the red cell into the classic crescent or sickle shape. So what kinds of conditions promote hemoglobin S polymerization and sickling? In short, any environment that's associated with low oxygen levels, increased acidity, or low blood volume, each embodied by the three horsemen of the apocalypse. The blue wheezing one up top, that's hypoxia. Less O2 available means more deoxygenated hemoglobin S. When the concentration of deoxygenated hemoglobin S surpasses about 60%, sickle hemoglobins start to bind each other and kick off a cycle of polymerization. This is the most important horseman to burn into your brain. Remember, it's the deoxyhemoglobin S that likes to polymerize. Next up, cellular dehydration. You can lead a red blood cell to water, but you can't make it drink. When the blood cell is dehydrated, this increases the intracellular concentration of hemoglobin S molecules. Decreased space between hemoglobin molecules makes it physically easier for them to come together and polymerize. And finally, acidosis is one of the classic factors that shifts the hemoglobin dissociation curve to the right. In more simple terms, that means hemoglobin gives up its oxygen more easily. And we all know by now that it's the deoxyhemoglobin S that likes to polymerize. These hemoglobin polymers can actually undergo multiple cycles of deoxygenation-induced polymerization, followed by reoxygenation and depolymerization. So, fortunately, with enough oxygen reducing the concentration of deoxyhemoglobin S, hemoglobin S polymers undo themselves and the RBC can recover its normal shape and function. However, the RBC can withstand only a finite number of these polymerization-depolymerization cycles before the cell membrane is irreversibly damaged and forever stuck in that classic sickle shape. When this happens, potassium starts to leak out and the cell dehydrates. Kinda like the crescent ship here, running aground and dehydrating. Cellular dehydration increases the relative concentration of hemoglobin S, thus causing even more polymerization, and the whole thing just spirals. As that stiffened hole cracks open, let it also remind you of a new lack of deformability of the cell membrane. This is extra bad, because RBCs need to undergo extreme alterations of shape as they pass through the spleen. These stiff sickled cells end up getting stuck, resulting in splenic sequestration and phagocytosis by macrophages of the reticuloendothelial system. Red cell death in the spleen, remember, is called extravascular hemolysis, symbolized by these lysed red skulls inside the splenic macro cage. Some cells, however, just aren't able to make it to the spleen in time, instead bursting open while still in circulation. This is called intravascular hemolysis. Overall, the average lifespan of RBCs is greatly reduced, only about 20 days, when it's supposed to be something like 120 days. The mixed-type hemolysis that ensues is predominantly extravascular, but you'll see signs of both intra- and extravascular hemolysis. Check out our extravascular tornado sketch, as well as our Hitchcockian intravascular sketch for all of the corresponding lab findings, including elevated LDH and unconjugated bilirubin. All right, let's get clinical. The manifestation of sickle cell disease depends on how many hemoglobin S alleles you have. Sickle cell disease is inherited in a classic autosomal recessive pattern, which we depict, as always, with our recessive shy kid. Orpheus's son, I presume. Patients with only one affected allele are said to have sickle cell trait, embodied in this scene by Orpheus's friend bringing up the rear. On his back, he is one of Karen's sickles, in addition to a beta scimitar, representing a hemoglobin S allele, along with a completely normal beta allele. It turns out that these patients are likely to experience very little hemolysis and no anemia. This is because the normal beta subunit allele is able to produce enough beta subunits to maintain a baseline level of normal adult hemoglobin and keep the concentration of deoxyhemoglobin S below that 60% threshold required to polymerize and form sickle RBCs. While sickle cell trait is typically asymptomatic, under extreme circumstances, clinically significant sickling can occur. This tends to happen only with severe hypoxia, in high altitudes, for example, dehydration, caused by things like strenuous exercise, or acidosis, as in severe sepsis or shock. Bottom line, conditions must be pretty rough to raise the concentration of deoxygenated hemoglobin S above the threshold needed to form polymers in a patient with only one copy of the hemoglobin S mutation. Like strenuously paddling against the river Styx current. That ought to do it. 2 copies of the hemoglobin S mutation, on the other hand, will result in true sickle cell disease. So let's make Karen's sickle an intimidating double sickle. No normal beta chains are produced. RBC sickling and hemolysis are much more extensive, leading to anemia, among other symptoms. Clinical manifestations of sickle cell begin after the first 6 months of life, when the shift from production of hemoglobin F to hemoglobin S is complete. Without fetal hemoglobin in the cell to intersperse between hemoglobin S molecules, long polymers of hemoglobin S build up, causing rampant sickling and hemolysis. Sickle RBCs are unique in that they're very sticky. Their damaged membranes, for some unknown reason, develop more adhesion molecules. As a result, these RBCs have a tendency to stick and roll along the walls of blood vessels. They also start adhering to each other, like the tethered boats in the back. These sticky cells have a propensity to occlude blood vessels, especially small ones in the periphery, where blood flows more slowly and the oxygen content is lower. Vaso-occlusion leads to the hallmark sequela associated with sickle cell disease. One important place where this happens is the spleen, which undergoes a series of unique changes over the first 2 decades of life. In early childhood, the spleen, filled with a ton of trapped RBCs, becomes congested and swells, as evoked by this enlarged splenic shield held by one of Orpheus's comrades, who's distracting Cerberus so Orpheus can make his move. Occlusion of the microvasculature in the spleen leads to transient ischemia, while RBCs plugging up the cords cause fibrosis. All of this damage adds up, and by the end of the first year of life, the spleen gets tired, becomes extra large, and loses most of its functionality. We actually call this splenic fatigue. You might remember from our extravascular hemolysis sketch that macrophages in the spleen are responsible for removing pieces of damaged membrane and intracellular inclusion bodies from RBCs that pass by. Num num num. As the spleen becomes less and less functional from splenic fatigue, though, the peripheral smear starts to show RBCs containing chunks of old DNA called Howell-Jolly bodies, which take the form of a little purple dot in the cytosol of red blood cells. Their presence on the smear should tip you off that the patient's spleen isn't doing its job. By adulthood, the spleen has scarred down to nothing more than a lump, a process called autosplenectomy. In other words, these patients functionally have no spleen, which leads to a number of unsavory consequences, including susceptibility to infection with certain types of bacteria. Specifically, functional asplenia leaves the body unable to trap and engulf encapsulated bacteria such as strep pneumo. This leaves patients with sickle cell at high risk of bacterial sepsis, which was previously the leading cause of death for these patients. Nowadays, thanks to preventative guidelines, mortality from sepsis has improved greatly. Daily prophylaxis with penicillin is recommended at least until age 5, and routine childhood vaccination is critical, especially for Streptococcus pneumoniae, Neisseria meningitidis, and Haemophilus influenza. Check out Sketchy Micro for more information on these encapsulated bugs. In addition to the spleen just not functioning, a potentially lethal complication known as splenic sequestration can occur. Sequestration occurs when a large blockage in the splenic circulation causes the spleen to rapidly swell with blood. The hallmarks of splenic sequestration are a large, tender spleen, a precipitous drop in hemoglobin and hematocrit, as the spleen captures a significant chunk of RBCs, and hypotension, since most of the blood is trapped and isn't being pumped through the body. Think of this poor unfortunate soul here, showing some serious hypotension as he's sequestered into the river, along with our recurring symbol for hemoglobin. Splenic sequestration is a big deal. The mortality rate can be as high as 10%, and recurrence is common. This phenomenon is exclusive to children, though, since the spleen inevitably scars down before adulthood, making the spleen too small and stiff to fill with blood. Similar to the thalassemias, the short lifespan of RBCs in sickle cell disease leaves very little reserve if the bone marrow suddenly decides to stop making RBCs, a phenomenon called aplastic crisis. Embodied by this ridiculously huge aplastic chew toy for Cerberus. Classically, aplastic crisis occurs in a child following infection with parvovirus B19. Keep aplastic crisis on your mind when the patient in the question stem presents shortly after a respiratory infection. Parvo much? Aplastic crisis and splenic sequestration can present similarly, so watch out. These two can be easily differentiated, however, by the reticulocyte count. In splenic sequestration, the retic count remains high, as the marrow tries to compensate by pumping out new red blood cells. These large, round, immature cells, laden with net-like chromatin, are represented by round chromatin tea bags. And hey, tea bags are like immature tea. Gotta steep it, son. Conversely, in aplastic crisis, as the marrow fails, so does reticulocyte production, so expect the retic count to plummet. As we already mentioned, sickle cells are sticky, and as they flow through small capillaries, they get stuck. This cuts off blood flow downstream and we call it vaso-occlusion, which can be very painful. And nothing says pain like a screaming skeleton. Vaso-occlusion and the microvasculature of the bones of the hands and feet lead to symptoms of swelling and pain in the fingers and toes, classically known as hand-foot syndrome, or dactylitis, illustrated here by Orpheus's final harp solo, channeling the power of Hades himself, as his hands transform into super skeleton shred machines. Dactylitis affects about half of all children with sickle cell disease, but is rarely seen after age 3. Likely because the bone matures, and hematopoiesis ceases in these areas. With repeat bouts of vaso-occlusion and pain, the bones of the hand and feet can become permanently necrosed and deformed. A combination of vaso-occlusion and marrow expansion leads to degenerative changes in long bones as well, especially the femoral head and humerus. This is called avascular necrosis, or osteonecrosis, and it's the most common reason for hip replacement surgery in these patients. The most lethal complication of sickle cell disease in children is acute chest syndrome. All kinds of things can set it off, including pulmonary infection, hypoventilation, atelectasis, thrombosis. Any one of these can lead to increased levels of deoxyhemoglobin S in the lungs. making RBCs sickle, stick together, and occlude vessels. Vaso-occlusion begets even more hypoxemia, which begets more RBC sickling and occlusion. It's a vicious downward spiral. Acute chest syndrome presents with symptoms of respiratory distress along with severe chest pain, like a sword to the chest. On chest x-ray, it shows up as pulmonary infiltrates, almost resembling a pneumonia, kinda like the infiltrate of fog obscuring the pulmonary sails. Don't delay with the fluids, oxygen, and pain control. Acute chest syndrome can be lethal. Another feared complication is ischemic stroke, caused by vaso-occlusion of cranial vessels. This is represented by a cracked helmet, complete with an ischemic stroke of hair on top. Stroke is the second most common cause of death for children with sickle cell disease, and is most often seen between the ages of 2 and 5. Vascular congestion of the penis can lead to a dangerous sustained erection called priapism. The hallmark of priapism is an erection lasting over 4 hours, just like the warnings in the erectile dysfunction commercials. This condition can be a surgical emergency because prolonged erection can cause ischemia and even infarction of penile tissue. So sheath that sword, my man. The relatively low oxygen content in the renal capillaries makes RBCs prone to sickling in the kidneys as well, leading to small infarcts. In the short term, this can manifest as hematuria. Over time, all of these microinfarcts can add up to significant chronic kidney injury, as evidenced by the beat-up kidney-shaped flank armor. In the face of chronic hemolysis, the body can upregulate RBC production to the extreme, so much so that hyperplasia of the marrow occurs, and it expands out of the medulla and into the cortex of bones. This is called extramedullary hematopoiesis. A stereotypical location where this happens is in the facial bones. See how expanded and bulgy the cheeks on that helmet are? This exam finding is called chipmunk facies. With extramedullary hematopoietic expansion into the cortex of the skull, a crew-cut appearance appears on X-ray. So we've added a mohawk to the helmet as well. With all of this badness, it seems like there's an evolutionary reason for the sickle cell gene to be so common. Sickle cell disorder and trait are most prevalent in sub-Saharan Africa, where 1 in 3 individuals carry the mutation. Other regions with higher prevalence rates include the Middle East and the Mediterranean. Just like with the thalassemias, it's believed that sickle cell trait confers an often life-saving protective effect from Plasmodium falciparum. Yep, that's not just a death veil. It's also a protective mosquito netting veil. How convenient. Remember, patients with sickle cell trait have 1 normal copy of the beta subunit gene and 1 abnormal sickle mutation. Therefore, with 1 functional beta allele, these patients are able to make regular old hemoglobin A1. This is adult hemoglobin composed of alpha and beta subunits. On hemoglobin electrophoresis, you'll see that S band for abnormal hemoglobin S production. However, a majority of hemoglobin will still be the normal adult A1 kind. Compare this with patients who have full-on sickle cell disease. 2 abnormal sickle alleles, in other words. These patients don't produce any normal beta subunits. Therefore, they're incapable of producing the normal adult hemoglobin A1. See? That A1 band all the way to the right is completely worn away. Also, you see that big F band? That's fetal hemoglobin, composed of gamma and alpha subunits. It's normally absent in adults, but individuals with sickle cell disease actually continue to produce hemoglobin F after 6 weeks of age. The body's all like, screw this, I'ma just keep making hemoglobin F. Gotta dilute that HbS. More like hemoglobin stupid face. Let this baby in Karen's arms remind you of this persistent hemoglobin F production. There are a few important goals in the management of sickle cell disease. 1. Pain management. 2. Infection prevention. 3. Prevention of complications. And 4. Rapid treatment when complications manifest. We mentioned a few specific therapies previously, such as penicillin prophylaxis for children and oxygen, aggressive hydration, and pain control when vaso-occlusive crises occur. But in addition to those, long-term management of sickle cell disease includes treatment with hydroxyurea, represented by the complementary River Styx hydrotherapy area. Kick back, relax, and enjoy the blissful weightlessness of having your soul reaped from your body. Enjoy. See how he's lifting up his baby too? The reason we use this classic chemotherapy drug for sickle cell disease is that it stimulates the production of fetal hemoglobin by somehow activating expression of the gamma subunit gene. Treatment with hydroxyurea has been shown to reduce complications and prolong survival in both children and adults. In fact, hydroxyurea is the only drug that's FDA approved for the treatment of sickle cell disease. Let's finish up with some unique variations of sickle cell disease. Let's say you only have one copy of the hemoglobin S mutation, but something happens to that other allele. It turns out that pretty much any other kind of beta subunit defect that hits the second gene will knock out normal beta subunit production, resulting in full-on sickle cell disease. Finally, let's kick it up a notch and introduce another variant form of the beta subunit, hemoglobin C. Hemoglobin C results from a missense mutation in the beta subunit gene that replaces the negatively charged glutamic acid in position 6 with a positively charged lysine, rather than the valine we saw in hemoglobin S. So not only did we incorporate a C shape into the top of the pike, this weapon is also great for lysing your opponents. Lysing, lysine, that just happened. Just like hemoglobin S, hemoglobin C is inherited in an autosomal recessive pattern. Having only one copy of the mutation confers an asymptomatic carrier state. 2 copies causes a mild hemolytic anemia that involves hemoglobin C precipitating as hexagonal crystals and damaging RBCs. When an individual inherits one copy of HBS and one copy of HBC, on the other hand, a disorder similar to sickle cell disease results. We call this hemoglobin SC disease. This change promotes the formation of hexagonal crystals, dehydration of the cell, and hydrophobic interactions with hemoglobin S. Generally, hemoglobin SC disease is milder than full-blown sickle cell disease, placing it somewhere between sickle cell trait and sickle cell disease.
All right, full disclosure. When I first heard the River Styx, I thought it'd be some kind of booze cruise with an awesome Styx cover band, not blood disgracious. In any case, let's jet through some of the more salient points about sickle cell disease. It all starts with a missense mutation of the beta-globin gene on chromosome 11, causing substitution of the normally hydrophilic glutamate with the hydrophobic valine. These sticky valines allow hemoglobin S to polymerize, which deforms red blood cell membranes into get this, a sickle shape. This makes them stiff and non-deformable, making them perfect fodder for sequestration in the spleen, extravascular hemolysis, or just explosion within vessels, intravascular hemolysis. Inherit one copy and you've got sickle cell trait, with no anemia and little to no sickling. Inherit 2 and you've got sickle cell disease, in conditions that promote sickling, such as hypoxia, dehydration, and acidosis. Enough red blood cells can sickle to cause pain crises, marked by bone pain, dactylitis, or even the feared acute chest syndrome. In severe cases, you can even see acute kidney injury with ATN, priapism, splenic sequestration syndrome, and even stroke. Chronic sickling leads to autosplenectomy, avascular necrosis of the femoral head, and extramedullary hematopoiesis. On electrophoresis, look for normal A bands in sickle trait, but hemoglobin S and even hemoglobin F bands with full-blown disease. Speaking of, treat these kids with hydroxyurea to increase hemoglobin F, and prophylactic penicillin until age 5, to ward off nasty encapsulated bugs, since they have a non-functional spleen and all. Well, that was no rockin' booze cruise, but
Would you like to join?
Oh, sorry. I don't have quite enough for, the fee.
Plus, it's creepy as hell down here.
Yeah. Dang. Would you look at that? Just out of cash.